Next, we call upon Dr. SAMYA MUJEEB to present the case on a seamless eye opener, a case series of patients with a mild ptosis.
Good morning, everyone. Today I'll be presenting a case series of patients who underwent MMCR surgery for mild ptosis. Muller's muscle conjunctival resection is described by Putterman and us. It is a minimally invasive surgery and it is posterior lamellar surgery with a good surgical outcome and a short learning curve. So the main aim of our study is to see the outcomes of MMCR surgery in patients with mild to moderate ptosis with a good LPS action. It is a prospective type of a case series of 25 eyes of 24 patients, and they were followed up post-operatively on day 1 week, and 1 month. All patients with mild to moderate ptosis with good LPS action were included. Patients with severe ptosis, poor LPS action, glaucoma and conjunctival disease were excluded. Preoperative and postoperative photographs and eyelid parameters were noted, and phenylephrine test was done so as to judge the amount of Muller's muscle that has to be resected. Moving on to the surgical procedure, which was done under local anesthesia. Double eversion of the upper lid was done. Then markings were done with the help of gentian violet and calipers based on the amount that had to be resected. So first, the markings were done at the superior border of the tarsal plate and then 4 to 4.5 millimeters beyond that. Then at the distal markings, 3 traction sutures were taken, central, medial and lateral. And then the 3 traction sutures were lifted up and then the Putterman's clamp was placed. Then 60 double-armed sutures, victral sutures were taken, and then they were passed in a serpentine fashion from lateral to medial and then back from medial to lateral. And then the Muller's muscle conjunctival complex was excised exactly between the Putterman's clamp and the sutures that were taken. And then the 2 sutures were externalized through the skin and tied up with or without a bolster. Coming to the results, 23 out of 25 eyes definitely did have a good, and as per how much we suspected, they had a good increase in the MRD1 and palpebral fissure height. The patients achieved an increase of MRD1 by 1.5 to 2 millimeters. 6 out of 25 patients had a negative result for phenylephrine test, and they also showed a good surgical outcome. These are 2 patients who underwent a right eye MMCR surgery, and you can see right from post-op day 1 to 1 month, there is a good lift and an aesthetically suitable outcome. 2 out of 25 patients definitely did show undercorrection, and the probable causes could be the slippage of the sutures, discontinuity of the continuous conjunctival sutures, and the malpositioning of the clamp. We can see that MMCR is a good posterior lamellar scarless surgery with an aesthetically pleasing outcome and had minimal tissue handling. It is noteworthy to say that eyelid elevation was achieved even in the 6 patients with negative phenylephrine test, and this could be due to the shortening of the posterior lamella and the advancement of the levator muscle, Muller's muscle and conjunctiva complex. So I hereby conclude by saying that MMCR is a seamless eye opener with no scars and minimum tissue excision. It gives a good desired lift, good eyelid contour, preserves the tarsals and meibomian glands, and irrespective of the phenylephrine test, the outcome was very good. Thank you.
Thank you. It was very interesting presentation. Is this working? So this MMCR is a known, this thing, surgical procedure, almost I must say standard of care for patients with mild ptosis. So in the category of moderate, how you also included moderate ptosis patients
Very
also?
few patients, ma'am, we did not, with a good LPS action, probably 2 to 3 millimeters of lift when it was required. MRD 2 and 1, we included them. Most of them had 2 millimeters.
So they also had good correction
They
that
had
way?
good correction. They had good correction. Only 2 patients had undercorrection. They also had a lift. They had an undercorrection, and both the patients were kids. So that is something we noted, and we thought probably because of the more extra activity of the muscle that children have LPS action, because it's congenital. Probably that is one thing we're going to look into, that why those 2 kids itself had undercorrection. But apart from that, all patients had a very
And
good
did you
outcome.
do suture removal in these patients?
We did not.
What suture you
We
used?
did not. We did not.
Acha,
not.
what
We
was the
just cut
suture
out-
you used?
We did double-armed 60 white drill was used, and we
Okay.
did not pull out the sutures. And if there was a bolster, we just cut out the bolster. That's all.
Okay, so do you know why Fasenala Servite has become less popular?
Because of the involvement of tarsus, ma'am, this tarsal compromise, and the patients started landing up with meibomian gland dysfunction. So that is completely nullified in this case.
So, do you think it's a meibomian gland dysfunction or some other problem which patients generally developed following Fasenala Servite surgery?
Meibomian gland, as well as when we touch the tarsal plate and excise it, it can sort of change the anatomy and the lid contour as well. Ma'am, the stability of the lid is compromised. And MMCR is actually a very easy procedure. It is known, but yet it is not practiced much. So the whole point of this presentation was not to just show its benefits, but to bring it back into practice more.
And you said around 4 to 5 only conjunctiva molars was removed, no?
No, ma'am. The markings was done 4 to 5 so almost 8 millimeter to 9 millimeter the section was done.
What is the longest follow-up you ran?
The longest follow-up, so 1 month itself. After that, the patients came back only if there was an undercorrection.
How much?
Otherwise,
1 month.
We followed up post-op 1 week.
Okay.
Removed the bolster, cut out the remaining part of the suture, and then we called them 1 month later. And obviously, we instructed them that if it comes down again, please come back to us. And none of them, the result was positive, apart from those 2 particular patients.
Did you confirm whether it is an ocular myasthenia? It's not an ocular myasthenia?
We did, sir. We ruled it out.
Okay.
We ruled it out.
Yeah, Dr. Samya, good presentation. How did you do phenylephrine test?
Phenylephrine test was actually done with 5% phenylephrine, ma'am, every 5 minutes for a period of 15 minutes. 5%.
So you put it for every 5 minutes.
Every 5 minutes for a period of 15 minutes, so 3 times. And then we check.
Consistent with height after
15 minutes, ma'am. So 3 times, 5 minutes, 5 minutes, 5 minutes. So 3 times.
So any possible relation between this correction of the phenylephrine test? Because 2 patients were undercorrected.
Yes, yes, ma'am.
So was there any relation between this phenylephrine response and the post-op outcome?
Post-op outcome, based on the phenylephrine test, we decided how much could be resected. But the patients who did not have a good phenylephrine test probably say the patient needs a 2 millimeter elevation, but phenylephrine test showed only 1 millimeter of elevation. We still took those patients up, and they achieved a good result, ma'am. So that's why 6 patients who had dissatisfactory phenylephrine tests, like not much of elevation, they also had a good outcome. And probably that is because of the conjunctiva, Muller's and levator complex posterior lamellar elevation. That's what I thank you.